So good afternoon, everybody. This is supposed to be March, but it's September. Welcome to our Emerging Scholars presentation. The Emerging Scholars program exists between UCSF and the University of Michigan and the University of Pennsylvania. And it's an opportunity for scholars who are sort of at the late, early stage of their career to have the opportunity to visit a campus in a health policy research institute, present their work and get feedback from colleagues around the country. And part of this is just to make sure that people doing great work have the chance to get out there and meet other people who can be part of their network. And then it's also an opportunity for the emerging scholars to have the opportunity to do something that looks like a practice job talk at this stage of their career. It's been an incredibly exciting program since it launched 3 years ago. There are a number of people I see who have joined us today who have participated in this program from UCSF and gone to the other campuses, and the reports back are always extremely positive. This year we were all queued up to have our emerging scholar visits. We actually managed to do some, but they were supposed to really be happening in March and April, and as we know, that didn't occur the way we planned. I'll spare you the optimistic rescheduling that we've done. While it can't happen in March, maybe it'll be in May, maybe in June, but here we are in our new COVID reality. So we're really delighted that Jeff Barnes is with us today, and we'll be doing his Emerging Scholar presentation virtually, as we do everything these days. Jeff is a physician at the University of Michigan. He's a doctor of cardiovascular medicine as well as vascular medicine. He's also a health services and health policy researcher. And he has a number of different different activities in his research, but one focus of his work is on implementation science. And that's some of the things we're going to be hearing about today in his talk. His research, although Jeff is an emerging scholar, his research has already been recognized by a number of different bodies and has won awards from colleagues from both cardiology and in vascular medicine. I'd say, looking at his CV, the award that really caught my eye, however, was the Golden Beeper Award, which honors medical student teaching, I believe, at the University of Michigan, right, Jeff? Yeah, right. So I think that's a wonderful wonderful name for award. And those awards are, I think, as anybody who teaches in a medical school knows, those are actually very meaningful ones that people really give a lot of thought to. So congratulations on. And I don't know if they give you an actual Golden Beeper, but that'd be wonderful if they had done that.
I wish.
Yeah. His career goal is to develop and implement system-level interventions to promote safe and effective medication management. And today he's going to talk about antithrombotic medicine management, how to build a system to improve care delivery. I'll just say on the technical side, Jeff has pre-recorded his talk. And once I'm done with this overly long introduction, Jay will hide our video and present the talk. While he is giving the talk, we encourage folks to put questions in the chat. I'll be keeping an eye on that and sort of moderating, and we'll return live after the talk is over, and hopefully all of you will also be live, and we'll be able to see you. And Jeff can answer questions that came up during the chat and have maybe even a real live Q&A as well. So thank you so much, Jeff, for joining us and sharing your work today. We're really looking forward to learning.
Hi, good afternoon. Thank you so much for having me. I'm really honored to be a part of this Emerging Scholars Exchange program between the University of Michigan, UCSF, and Penn. And it's a real pleasure for me to get to come today and talk to you about some work that I've been doing here at the University of Michigan and broader within the state of Michigan. Today's talk, I'm going to focus on antithrombotic medication management. And I'm sort of doing this under the guise of how we're building systems to improve care delivery. I do have some disclosures, primarily around some consulting for companies that make anticoagulants, as well as the way anticoagulant care is delivered, and some national advocacy work as well. I want to use today's talk to really tell you 3 different stories. The first is a story about a system redesign that we have implemented over time and evaluated to improve anticoagulation care. The second is the way we are envisioning broadening the role of the Anticoagulation Clinic. And then the third is one that we've actually just recently started, which I'm going to call Work Smarter, Not Harder. And I'll tell you a little bit more about that. But why don't we get started with this first story of a system redesign aimed at improving care. So for those of you who don't spend a lot of time thinking about blood thinning medicines or antithrombotic medicines, these are actually the #1 cause of adverse drug events in the United States. This is data that was from earlier this, about 5 or 6 years ago now, looking at emergency department visits for patients who had some adverse reaction to their medication. And far and away, the most common medicine to cause that was warfarin. This is an anticoagulant or a blood thinner we've been using literally for decades. #3 on that list is clopidogrel, an antiplatelet medicine we often use after getting a heart stent. #5 is aspirin, and then a little farther down that list is a medicine called rivaroxaban, which is one of the newer anticoagulants. If we were to update this data now, we would see some of the other new anticoagulants pop up on this picture. But clearly these are medicines that, when not managed appropriately, can really put patients at risk for harm. That's particularly true when patients are undergoing some sort of a surgical procedure, because these are medicines that we use to prevent clots, but they also have a risk of bleeding. And of course, during the time of a surgery, the surgeons are really trying to do everything they can to avoid any bleeding complications. And so there's this balancing act that's going on. How do we avoid the clotting that is the reason you're on the blood thinner, with also avoiding the bleeding that comes with surgery? And one key question that often comes up is, should we be stopping these medicines before a surgery? And if so, when do we stop the medicines before surgery? And if we're going to stop them, do we need some sort of a bridge or a gap to help cover that time period? And I'm going to get into that here in a little bit. So lots of complicated management questions we have to think through. And this isn't just sort of a one-off kind of question. This is a question we clinically encounter all the time. Atrial fibrillation is one of the most common reasons people are on blood thinners, anticoagulants, and these patients are undergoing surgical procedures more than 500,000 times a year. So this is something that we are constantly encountering, and there may be an opportunity for us to improve the overall care delivery system. Now, I talked a little bit about how there's lots of different medicines, and unfortunately, each of these different medicines have different properties. So again, for those who aren't as familiar with the cardiology and the anticoagulation literature, warfarin, which I'm showing you here on the left side, also goes by the brand name Coumadin. This is the drug we've been using literally for 5 decades. It's really dependable. We know how to use it. But one of the biggest downsides is it has this long half-life, meaning when you make a change, it takes a long time for that to take effect. So for instance, if I know I'm going to have a surgical procedure and I want all the effects of warfarin out of somebody's system, I've got to stop that drug 5 days ahead of time to let it wear out of the system. And then if I restart warfarin after their procedure, it could take 5, 10, maybe even 15 days before the warfarin effect is back up in the therapeutic range. Now, that's very different than these newer drugs that have been out for now just about a decade or so. These are called the direct oral anticoagulants. These drugs have much shorter half-life. So when you stop them, they wear out of your system in about a day or two. And when you restart them, they're fully therapeutic within a couple hours. So very different pharmacologic properties between these two drugs. And it's important that clinicians understand how to manage them uniquely. Now with warfarin, we talked about the fact that there's this long gap of when it wears out of your system and builds back up. And for some patients, we're so concerned about their clotting risk that we say we probably need to somehow bridge that gap. We don't want them exposed to clot for that many days. So ideally, we could come up with some strategy that sort of fills in the gap. That's what this sort of, peach color is here compared to the blue. That's, of course, the ideal world. The reality, unfortunately, isn't so clean. In reality, what we have is the ability to give somebody a short-acting blood thinner called heparin, usually as an injection or maybe as an IV, but we can't really titrate the amount of effect the way we'd like. So we end up giving them a full therapeutic dose of heparin on top of whatever warfarin effect's going on. So you get this sort of period around surgery where they might even be super therapeutic or overly anticoagulated because we're trying to bridge them. You can imagine that if you get a little bit too much of the two blood thinners together, that puts you at risk for bleeding. And so there's this kind of, again, this tug and pull between, do we want to protect against a clot or do we want to try and avoid bleeding? This was actually the main focus of a big randomized trial that was done and published now 5 years ago called the Bridge trial. And in this trial, they took people who were on warfarin, who they knew were going to have a procedure, and they randomized them so that half of them got one of these heparin drugs before and after surgery. In this case, they used one called dalteparin. The other half got placebo. And the big question here was, do you get any benefit from getting this bridging low molecular weight heparin, this dalteparin? Or are you better off just taking that gap of, 3 to 4 days before surgery and, 5 or so days after surgery? Sort of, what's the best strategy to use? And there's, of course, a lot of nuance with any clinical trial, but I'm just going to cut to the chase for the purpose of our talk here. The main outcomes in just shy of 2,000 patients showed overall the event rates, the stroke or the clotting event rates that we're worried about in these patients were really low. And they were not different between the two groups. So there wasn't any meaningful protection amongst the patients who got that bridging low molecular weight heparin. Now, what about the opposite side? Was there any downside to getting it? And the answer was yes. Major bleeding, so bleeding that required a transfusion, where people lost a lot of blood, maybe needed a surgical procedure, that was significantly more common in the people who got the bridging, about 2%, absolute 2% more, a number needed to harm of about 53. If you look at sort of a broader picture, the minor bleeds, ones that maybe caused people to call their doctor, but they didn't require a transfusion, maybe they didn't require surgery, these were really common. Up to 21% of patients who received bridging had some sort of a bleeding, number needed to harm of 11. So overall, when I look at the study, I say, you're not really getting any benefit, but probably 1 in 10 patients getting bridge is going to have some sort of an adverse event related to it. So the standard therapy is probably not to go ahead and bridge those patients. This is even applicable to patients who we think of as being highest risk because they've had a prior stroke. 15% of this overall population had prior stroke or a mini stroke, a transient ischemic attack. So these data do even relate to those patients. So armed with this information, we really wanted to know within sort of our center and more locally across the state, what's the current state of knowledge around bridging and what do people know about the different management strategies? So we actually conducted a survey of cardiologists, primary care providers, both internists and family med docs, as well as some GI doctors. And we did that because we created some clinical scenarios where patients had atrial fibrillation and they were taking warfarin, just like was in that bridge trial, and they needed to stop it because they were going to have a colonoscopy. And what we did is we varied the stroke risk of the patients in the different scenarios, the low, the moderate, and the high stroke risk using the standardized score called the CHADS-2 score. We also varied within there whether or not the patient had a prior history of stroke because we really wanted to understand how that was influencing clinician behavior. And the results were really kind of interesting. On the left side of this graph, what you see is the patients who were at lowest risk for stroke, pretty much universally the docs and clinicians said, nope, they don't need any bridging. And that's what the evidence would suggest. And then all the way over to the right-hand side of the graph, those who are at highest risk of stroke, they previously had a stroke, pretty much most people said, yeah, I think I'm going to bridge them because I'm pretty concerned. And I think you could make a decent argument for that based on the data that's out there. But the middle of the graph is where things are fascinating. These two bars in the middle, they both have this CHAD score of 3, meaning they're both at the same intermediate risk of stroke. You see a lot of variation in practice, not just between those patient scenarios with prior stroke and no prior stroke, but even among the different specialists, where cardiologists were going to be least likely to bridge and the family medicine docs were going to be most likely to bridge, tons of variation. I mean, and to the point where sometimes it's even a 3-fold or greater variation. So we really said here, wow, this wide area of variation, is there potential that we might need to better educate our providers and better empower them with the evidence to make these decisions? We also asked them whether their institutions, and we did this amongst a number of different institutions in Michigan, we said, do your institutions have appropriate mechanisms to help you manage this, or do you need some better mechanisms? And we found that the majority of docs, especially the GI docs and the primary care docs, said, yeah, we do think we need some more support from our institution. And then we said, well, do you think your anticoagulation clinic could potentially play a role, and would you support that? And overwhelmingly, everyone said, yes, we would love to have support from our anticoagulation clinic as it pertains to this peri-procedural management. So armed with that, we started to come up with this conceptual model. And this was sort of the framework for the work that was done on my NHLBIK award. We said, you know, so often patients are sort of stuck with this communication conundrum where a surgeon or proceduralist may be trying to talk with a pre-op clinic or an anticoagulation clinic or other providers to try and figure out how to manage these blood thinning medicines before surgery. And there's no clear pathway. And often the patient just gets confused and they're not sure what to do. And we asked ourselves, could we reorganize this? Could we come up with a streamlined process by which we put one person in the middle? Maybe it's the anticoagulation clinic. We create some evidence-based protocols, and that becomes the primary contact point for our patients. And then they could also reach out to other specialists as needed to get more support. So this was sort of the conceptual model we worked on as we endeavored on this project. So our goal for this project was to understand the current state of peri-procedural anticoagulation around one procedure, elective GI endoscopy. We then wanted to develop an implementation plan for how we would redesign this to actually get evidence-based practice into play. And then we wanted to go ahead and implement that at our center at the University of Michigan and see what happened. So we gathered some baseline data, and we found that we were having about 6 endoscopic cases a day where patients were taking some antithrombotic medicine, either an anticoagulant like Coumadin or an antiplatelet medicine like clopidogrel. We then called the patients and we said, well, how has your experience been? Are you satisfied with care? Or are you concerned about what's going on? We found that about 1 in 5 of our patients said, look, I'm dissatisfied with how my care was coordinated for this procedure. I wasn't sure who to talk to. I wasn't sure exactly how to manage things. And then we asked our endoscopy nurses to just take a quick tally and say, hey, how often are patients coming in for this procedure and there's something wrong with how their meds were managed? And that similarly, about 1 in 5, 1 in 6, 17% of these patients were mismanaging their medicine. Maybe they didn't hold it at the right time or they did something wrong. And about 1 in 20, 6% of these cases, they just had to cancel outright because patient was still on warfarin, we couldn't do the procedure, they hadn't stopped clopidogrel, something like that. So we were having a number of cases that were canceled after the room was reserved, after the patient had gone through prep, all those sorts of things. I think there was a real clear opportunity here to be able to improve care. So we assembled our project team and we tried to be as broad and inclusive as possible. We had physicians from a number of different specialties that all related to this project. We also brought in some pharmacists from our anticoagulation clinic. We wanted to make sure we had nursing representation from both the clinic and the procedure perspective. We also knew that a lot of stuff happened around scheduling, so we got a scheduler involved in our project. We wanted to make sure the patient voice was really well heard, so we had 2 different patients on our team. And you know, nowadays, anything you do, it's likely to involve a electronic health record design. And so we actually had some IT members on our team, as well as a performance improvement coach. We actually spent about 3 months digging into the process and came up with a really detailed process map of how care was being delivered. And this is sort of a high-level summary, but essentially we came up with 5 key steps here. The first step was somebody had to order this endoscopy. And that could happen within our system from a GI specialist or from a primary care doc most of the time. But we also get a lot of these coming in from the community. So a non-University of Michigan doctor requesting a procedure be done at our center. We then said, well, who's identifying the med use? And interestingly, it was the GI scheduler. So somebody who doesn't really have any medical training was being asked, you know, to figure out if patients were taking blood thinners. They literally would ask the patient, do you take a blood thinner? Do you have diabetes? You know, they went through those screening questions. And if the answer to the blood thinner question was yes, the GI scheduler would say to the patient, you need to contact your provider who manages your blood thinner to figure out what to do. So we put all of the responsibility on the patient. And then the patient had to figure out how to contact them, who to contact, which of their medicines is even a blood thinner, right? Like they had to sort all that out and try and figure out who is going to make these decisions for managing their medicine. And then instructions on how to do this, totally ad hoc, depending on who they talk to. And then whether or not that got checked right before surgery, again, we didn't have really any process around that. So you can imagine the myriad of ways this process could go wrong. We decided to key in on two of them. We said, hey, look, who identifies that a patient is on a blood thinner? This is not ideal, leaving it up to non-medically trained people. And who's responsible for communication and decision-making? This should not be something we're putting on the patient. We need to come up with a better solution. So we came up with a few guiding principles to say, how could we reorganize this? How can we be accountable to our patients so that the health system is going to own this coordination process? It's not a patient responsibility. We wanted to make sure that what we were doing was being transparent to all of our patients and providers. We wanted to make sure that decisions were clearly communicated and that our care was as consistent and evidence-based as possible. We wanted our process to be robust. If you remember, I showed you on the last slide that many of our endoscopy orders were coming from inside our system, our own docs, but many also came from outside. And how could this process encompass all of those so that we didn't hurt our endoscopy referral process? And as you know, some people would believe, how do we minimize reliance on humans to identify cases? Can we use some sort of automated triggers in our electronic medical record? So those were sort of the principles we used to engage with this process. And after about another 2 months worth of work, we came up with this new process where after the endoscopy is ordered, now we're going to have the electronic medical record figure out that this is a patient on a blood thinner and automatically issue an alert. And I'll show you what that alert looks like next. Based on that alert, we're going to recommend that the Anticoagulation Clinic be responsible for coordinating this. So we're going to put in a referral and we're going to empower those pharmacists in the Anticoagulation Clinic with institutional guidelines on exactly how these drugs should be managed. They're also going to document their instructions and they're going to give the patient the specific instructions that they need. And we spent a lot of time working with our patients to make sure that our instructions were understandable. One easy example is instead of telling the patient, hold your warfarin for 5 days before surgery, what does that mean? On day 5, do I take it that day or not take it? It became confusing. We started printing out calendars. So on Monday, you take your pills, on Tuesday, you don't take your pills, and on Friday, you have your procedure, right? So we tried to make it as transparent as possible for the patients. And then with that documentation in the chart, the endoscopy nurse could quickly check it before procedure and make sure the patient had actually followed the recommended instructions. This is the best practice advisory that we developed. We're an Epic-based system. And so we came up with this quick alert when the system found that you ordered endoscopies and you were on a blood thinner, this popped up. And it basically says, hey, your patient's taking a blood thinner, they're being referred for a procedure. Would you like the Anticoagulation Clinic to manage this? It was preset to say order. And so all you have to do is click accept. We wanted to make doing the right thing here as easy as possible, sort of that behavioral economics sort of piece in there, right? The easiest thing is to just click yes, get the referral off, and the pharmacist is going to take care of all of this. It reduces the burden. And this is something we've heard over and over again from our primary care clinicians and our GI clinicians. It's so easy. It makes it really, really streamlined for me. But also some clinicians could customize this, right? They could put a comment in there and say to the pharmacist, hey, this is somebody I'm really worried about. Could you manage it in this way or that way? So people could have an ability to customize, but it was still an easy alert and an easy process to sort of engage with. So here were some of the initial outcome data that we saw. So in the baseline, those are some of the numbers I'd shown you before. Inappropriate med management, again, about 17% early on, dropped to 2% after we implemented this. Cancellations dropped from 6% down to 2%. Patient satisfaction went from 80% up to 95%. And when we surveyed our physicians and we said, hey, are you satisfied with how this process goes? We went from a minority being satisfied to an overwhelming majority. We even looked at how often procedures were being canceled within 24 hours, and they are sometimes related to blood thinners, sometimes related to other things, but we saw a drop there as well. In fact, my operational partners estimated that we're saving about $250,000 in lost billing because we're not canceling those procedures. We're able to actually utilize the room and engage with and care for patients there. So we were able to even make a financial justification for the process. We've continued to follow this. And so on the left side of the screen, you can see during the pilot phase, as we sort of rolled out this referral process, it was being used more and more frequently. And roughly about 2/3 of the time when these things popped up, the clinicians would go ahead and refer to our anticoagulation clinic. By April of 2018, we had implemented this across our entire health system. And for the entire rest of that year, we saw a pretty consistent pattern of both number of cases being alerted and the overall referral, somewhere in that 2/3 to 3/4 range. So we felt like that was some pretty good adoption across our health system. And we've looked at that data now in 2019 and into 2020, and it's been maintained really well. There was obviously a dip when COVID hit this spring, but overall, we've had really good maintenance of this process. When we asked our clinicians whether they were happy with this, absolutely. On the right side, these are some survey questions, and the lighter colors are the ones that show more positive results. So after we implemented this BPA, people said, yes, we think the institution has some great processes in place. And then the second star down there, are there things that the institution could do more to help? Fewer people said that they needed help. They felt like the institution was doing enough. So we felt like the overall implementation of this process, this care redesign, was really quite effective. Okay, I'm going to turn now to our second story. This is a story of broadening the role of the anticoagulation clinic. I kind of touched on that in the last one, engaging more with peri-procedural care, but I want to talk about that in a little bit broader context. Historically, the anticoagulation clinic, or what's often referred to as the Coumadin clinic, was designed to manage this complex drug of Coumadin or warfarin because of all of the dose adjustments, the INRs going up and down, all of this. So you operationalize it with nurses or pharmacists who check an INR, tell a patient to adjust their dose, tell them when to recheck their drug. And that's sort of the core of what these clinics do. But there's so much more that they could do because they're really expert in these drugs, right? Many of these could assist with drug or dose selection. Should your patient be on warfarin or one of the direct oral anticoagulants? And if so, what's the right drug and right dose to be on? There's expertise here that can help. Are there ways we can minimize bleeding risk? We talked in the last story about the peri-procedural piece. What about patients taking multiple blood thinners? Maybe they're on warfarin and they're on some antiplatelet agents. What about helping with lab monitoring? What about even helping with med adherence, right? There's lots of things that we could do that would expand the role of the clinic and really help care for our patients. I'm going to focus on this story of the multiple antithrombotics. This has been a really big focus in the area of cardiovascular medicine over the last maybe 5 years or so. And we thought that there was an opportunity here to really make an impact. We know that patients who take multiple blood thinners are at significantly increased risk of bleeding. This is some data from Europe showing that if you only take one blood thinner, whether it's warfarin or aspirin or clopidogrel, you have, give or take, some relatively similar rate of having major bleeding. But once you start combining those, so aspirin and clopidogrel or dual antiplatelet, or warfarin and aspirin, or even if you get to the point where you're on all three, so triple therapy, your risk of major bleeding goes up significantly. So those are patients for whom we might want to target whether or not this is an effective strategy or not. At the same time, there had been a number of studies that were published in the last few years, really challenging the notion that aspirin as a primary prevention strategy for cardiovascular disease is highly effective. I think it used to be fairly standard that many or most patients, especially men over 50, would be put on a baby aspirin, but that may not be the best strategy for people across the board. And that's especially true if you're already taking an anticoagulant like warfarin, because now you've already got some protection from the warfarin, and you take these two drugs together and your bleeding risk goes up. So we thought that there was an opportunity to try and really focus in on that population. So we used a collaborative that we have in the state of Michigan called the Michigan Anticoagulation Quality Improvement Initiative. This is a collaborative of 6 health systems. And across those health systems, we looked for patients who were on warfarin. who were taking that either because they had atrial fibrillation or a venous thromboembolism, and they were going to be followed for at least 3 months. We wanted these people to be in sort of the steady state of things. We excluded anyone who had a valve replacement or anyone who had a recent myocardial infarction, reasons that they would likely need to be on aspirin as well. And then we said, okay, how many of them are on aspirin or not on aspirin at the time of enrollment? And let's sort of look at the differences there. And what we found was kind of interesting. Somewhere around a third to 40% of patients across the time period from 2010 to 2016 were taking aspirin without any real clear indication for it. We did thankfully note that the vast majority were using a baby aspirin, so 81 milligrams a day. But still, we felt like there was this potential for inappropriate aspirin use amongst this population. Then we started to look at what outcomes they were experiencing. And as you might guess, bleeding rates were higher. So on the left side, we look at major bleeding events. The patients who are on warfarin and aspirin together are on the dark line, and those who are on warfarin alone are on the lighter, the yellow or orange line. And the rates at 1 year, 2 years, and even 3 years out from starting warfarin were significantly higher in patients who were taking dual therapy, just like we had seen in that study from Europe. Similarly, on the right side of the screen, you see the hospitalization rates because of bleeding. And again, higher rates of bleeding-related hospitalization in patients on warfarin and aspirin together. But maybe it's beneficial because maybe it helps to prevent heart attacks and strokes and things like that. Unfortunately, we didn't see any benefit here. So overall, no difference, again, at 1, 2, and 3 years, no statistically significant difference in the rate of thrombotic events, meaning heart attacks, stroke, peripheral embolism, things like that. So bleeding risk, no benefit. Seems like this is an opportunity to try and de-prescribe aspirin and help avoid some adverse events here. So we actually engaged in a QI process across our health systems. Again, these are 6 different health systems, and they're all a little unique. Some are academic, like the University of Michigan. Most are non-academic. Some use nurses in their anticoagulation clinic, others use pharmacists, and some have a combination of the two. Some of our anticoagulation clinics are totally phone-based. We never see anyone face-to-face. Others are a more face-to-face model where patients come in and they'll see a nurse or a pharmacist to talk about their care. Some of our health systems are very much integrated, and so all of our specialists work together under one physician group. Others are a little bit more traditional, where they have multiple physician groups or multiple doctors' offices all sort of interfacing with the health system. So a lot of variation that we had. But we said our goal is to identify patients who we think might be on inappropriate aspirin use, come up with some form for contacting the provider, usually using a templated note or something like that, and then see if we could assist those providers with aspirin de-prescribing. Could we get patients off aspirin and see if it would help to avoid bleeding complications? And here's sort of the numbers as we look at it. So our overall rates of aspirin use plotted by quarter, going back all the way to 2010, hovering in that 25 to 30% range. And then each of those dashed lines here represents when each of the different health systems sort of implemented their process. So that all happened right around the beginning of 2018. And you can see this rapid decline in the rate of inappropriate aspirin use. And again, we define that as, aspirin use without an indication like valve disease, recent MI, things like that. On the right side, the clinical outcomes got better as well. So in the pre-intervention group, about 26% of patients had any bleeding. That dropped to, 26 per 100 patient years had any bleeding. That dropped to 17 per 100 patient years. The major bleeding dropped from 4 down to 3. The clinically relevant non-major bleeding dropped. And thankfully, we did not see any difference in the overall rate of thrombosis in the patients in the pre and the post-intervention group. So we're really optimistic that we think we've been able to make a meaningful change for our patients without causing any harm. So the next steps for this process are, well, how do we sustain this long term? We've had this up and running now for a couple of years. We think we've sort of hit a sustainment model, but we're always sort of checking that. Is there opportunity to expand this? And so we're actually working now on a way that we might be able to expand this, not just to the warfarin patients on inappropriate aspirin, but now the patients taking those other oral anticoagulants, the direct oral anticoagulants. How about those patients who are also on aspirin? They're not traditionally followed in our anticoagulation clinic, but maybe there's a way that we can sort of use our systems to identify them and try and get them off aspirin if that's appropriate. There's of course questions about which patients need and don't need aspirin therapy. We focused on sort of the low-hanging fruit, those with no history of coronary disease at all. But maybe we could even get at patients who have quote unquote stable coronary disease. Maybe their last coronary stent or their last heart attack was more than a year ago. We now have some randomized trial data telling us it's probably safe to continue them just on anticoagulation alone when they're in that stable period. Could we sort of expand our process to them? And in the end, if we can't stop the aspirin, if they're going to need to be on these multiple blood thinners, is there anything else we can do to avoid bleeding? Maybe they should be initiated on a PPI. So we're sort of working on a couple of these processes right now to continue to improve safe care for our patients. All of this centered within our anticoagulation clinic. Okay, so the last story I want to tell you is a story about working smarter, not harder. And this is actually a phrase that I borrow from a good friend of mine, Arthur Allen. Arthur is a pharmacist at the Salt Lake City VA, and he and I were having conversations about a lot of these processes, and he said, you know, now that we've got all these patients on direct oral anticoagulants, some people think we just need to sort of buckle down and sort of figure out how to manage our DOAC patients in the same way we manage our warfarin patients, which is very much manual. Each patient comes in, you look at their labs, you review their chart, and you figure out what to do. And he said, there's got to be a better way. How do we make ourselves working smarter, not just harder? And this is particularly important because these direct oral anticoagulants have very different dosing approaches than warfarin. Warfarin was pretty easy. You pick an INR target range, almost always 2 to 3, and then you put some expert nurses or pharmacists in charge of sort of managing that. Patients get their blood draw, you adjust their dose, and that happens. And there's sort of, they can operationalize that pretty well. But with these new drugs, there's a lot of nuance. You pick a dose, you can't really check to make sure it's appropriate, but each drug has a different dose, and each indication for that drug has a different set of doses. And those are going to vary based on renal function and liver function and drug-drug interactions. So it can get kind of complicated. And this is some data showing just how often patients are getting inappropriate drug or dose selection. This is based on FDA prescribing recommendations. On the left side of the screen is some data from the Orbit AF registry. This was a large national registry looking at patients with atrial fibrillation. And what you see here is that about 12% of patients have some sort of inappropriate prescription, inappropriate dosing of their direct oral anticoagulant, usually underdosing, but sometimes overdosing. And in those patients who are either under or overdosed, you can see higher rates of bleeding, higher rates of stroke and systemic embolism, higher rates of hospitalization, and higher rates of mortality. Now, I'm not going to say that's all just because of the drugs, but there's probably an element of the dosing that's playing into some of those outcomes. When we looked at our own experience, and this is at 4 centers in the state of Michigan, we found some pretty similar numbers. About 12.8% of patients had an inappropriate drug or dose selected when they were put on a DOAC. So we said, wow, there's an opportunity for us to really make an impact here on how our patients are getting safe prescribing of their anticoagulants. And so we started to think about whether population health approaches could work. Again, patients aren't referred to our anticoagulation clinic, so we need to go out and find them. And so the model, the conceptual model we're really thinking about here is one where a pharmacist or a nurse can partner with an electronic medical record tool to identify all patients within a system who take these drugs, and then let the computer system pull out the patients who have potential dosing errors, finding those needles in the haystack. So rather than a nurse or pharmacist having to review, literally hundreds or thousands of patients to see who has errors, they can sort of say, oh, these are the 40 patients for whom the system thinks are most likely to have an error. Let's go through and figure out if we can actually review the case and make some sort of an intervention. We started to do this with a QI process. This was built into our registry. We looked at just a small cohort of patients, and we found in these 560 patients, about 11% of them had a potentially inappropriate DOAC use. Now, these were screened by some research staff. So then we ask them to contact the physician or pharmacist in charge of their site to verify that, yep, this is correct. And again, overwhelmingly, the majority of those, they said, yep, that seems to be appropriate. Now, because of the research process we had in place, we often don't catch this right when a drug's prescribed. And so many times the physician at the site didn't contact the prescribing doc, the research physician didn't contact the prescribing doc because too much time had lapsed before we did our research data abstraction. But when we did go ahead and contact those prescribers, we found that 2/3 of the time, the prescriber said, oh, thank you for telling me, I'm gonna go ahead and make a change. So we felt like there was an opportunity to inform prescribers and make meaningful changes. Unfortunately, this model using this sort of research approach means that we were only impacting about 1/4 of all patients where we initially found an inappropriate prescription. So we have to figure out a better way to operationalize this whole process. And so what we're doing now is we're actually developing something called the DOAC dashboard. I'm going to show you what it looks like here. Essentially, we want to create a dashboard, and we've actually done this, where we can search across our entire health system to identify all patients who are taking one of these drugs. So in this example, 1,536 patients. Of those, the system has identified 37 potential flags where there may be something wrong with the prescription. They can even group them into which are critical versus which are less critical. So we know which ones we really need to focus our attention on versus which we can get to when it's more available. And then you can actually see all the information you need to make a good informed decision. So the first patient here, patient X, I know how old they are, I know what drug and dose they're taking and why they seem to be taking it. I've got some key laboratory data and when those labs were actually monitored. I get a measure of their creatinine clearance. Again, most systems don't calculate that automatically. They use a GFR. We need a creatinine clearance to dose these appropriately. It'll highlight any important drug-drug interactions. And there's an opportunity for me to even write a note to myself. Hey, I'm not worried about this, or hey, let's come back and recheck this in 6 months. So this is a great way for a pharmacist or a nurse to be able to actively engage with an entire cohort of patients, literally thousands of patients if needed on a regular basis, and focus their energy on the patients who have the most pressing concerns. We've designed this, we've implemented it now at the University of Michigan. We're in the process of implementing it at 3 other health systems in our state. And our goal is, once we finish implementing this, to make this available to any system who's using Epic so that they could similarly create a process like this. This was very much inspired by something that the VA has. And I know some of the colleagues there at UCSF who work at the VA in San Francisco are familiar with this dashboard that's now being used nationally. So we took that inspiration, we're trying to build it for Epic, and then we want to see this expanded if it's shown to be effective. So part of our process, and this is a grant we have through AHRQ, is to really evaluate and implement this. So we're going to start with the VA experience. They've been using this now for a couple years, about 2 to 3 years. So we want to understand what that has been and evaluate their implementation using a commonly used implementation evaluation framework called the REAIM framework. What's been the reach? How effective is this tool? How widely is it being adopted? What's the implementation process like, and is it being maintained? We are also in the process of doing some interviews with key stakeholders, pharmacists, nurses, IT folks, managers, to understand what were the barriers to implementing this and to using it. We're doing a bunch of those in the VA to really get a good experience, but we've also done that in our Mackey site, sort of an anticipatory barriers evaluation. And we're going to use both what we learned from the VA with people who actually implemented this and what our non-VA centers are anticipating to come up with a implementation strategy that we think is going to help us implement this and get it used effectively across our different centers in Michigan. And then, of course, once we implement it, we'll go ahead and actually assess its evaluation using that same REAIM framework. So to summarize, I've told you 3 different stories of work we're doing. We've been redesigning care delivery, where we're going through and detailing our current processes for how we deliver care, especially in the perioperative procedure time frame. We're using team-based care redesign and really leveraging our pharmacist colleagues to help us. And we're using implementation strategies and behavioral economic sort of theories to say, let's make the right choice, the easy choice for our clinicians so that we can optimize care for patients. We're also working on expanding the role of the anticoagulation clinic. When possible, we're trying to de-prescribe unnecessary and high-risk medications like aspirin. And then we're thinking about, if we can't do that, what's our second line strategy? Could we think about initiating a PPI, for instance, in some of our high-risk patients? And so can the anticoagulation clinic really play a role in this, expand their traditional monitoring of labs and adjusting doses of warfarin to doing some of these other elements? And of course, the work we're really getting into now, we're working smarter, not harder. We're using population health tools built into our electronic medical records so that our pharmacists and nurses who have a lot of expertise, that we can bring that to all patients taking these drugs, not just the ones who are being referred in. And so these are different ways in which we're trying to think about using electronic health tools, using our broad teams of care, and using different implementation strategies to improve care for patients broadly. I want to acknowledge so many mentors and collaborators who've been helping me and working with me on these different projects, and you can see many of their names here. Acknowledge funding for 2 of these big projects through NHLBI as well as AHRQ. And of course, the Mackey Collaborative. This is the Quality Improvement Collaborative in Michigan, which is funded by Blue Cross Blue Shield of Michigan. And then lastly, a big thank you to the 3 centers that participate in this Emerging Scholars Exchange Program, and a special thank you to all of you at UCSF for having me. It's really been a wonderful week. I've really enjoyed getting to meet many of you and talk about our shared research interests. And thank you for spending the time to hear some of the work that we've been doing. And at this time, I'd be happy to entertain any questions that you might have.
Thanks for a great presentation. I was particularly curious about your use of the EHR and best practice alerts and other EHR-based interventions. I think that's a really promising area of intervention because it seems like it would be something that could be widely disseminated. But the truth is, I think, as you know, that every medical system, health system, other than the VA, has their own version of the EHR. Even if it's Epic, it's a different version of Epic. And so each organization would have to basically build your intervention from scratch, which is often a barrier basically to dissemination. I was wondering if you had thoughts on how we could better streamline that, or there are ways that we could facilitate more widespread dissemination of work like yours.
Yeah, Grace, thanks so much. It's a really great question. And there's a couple pieces that I'll reflect on. The first is that anytime we build a tool in the EHR, it doesn't stand on its own. There's often a process around it. And so just building a best practice alert in and of itself may not be the full solution. So if we think about that first story I told you with the perioperative piece, you could build a best practice alert, but if you don't have the process of the referral, the anticoagulation clinic ready with the guidelines and the staffing, it won't work. So you have to sort of have that whole piece together. So that's clearly a barrier to sort of broad dissemination. I would say, secondly, I think as we develop these tools, we probably need to be responsible about saying, can we come up with these sort of IT implementation playbooks, right? So how would you build this in your own center? And I think that's where the companies probably need to have a little bit of incentive to encourage folks to do that. So my team that built it should be able to put that playbook out in a place that any other Epic center can quickly grab. When you think about some other programs, there's a new tool within Epic that's called the turbocharger, and it's actually a tool we're using now for that dashboard I told you about. And it's a way to sort of rapidly get a big chunk of the programming transferred over. My Epic programmers tell me it probably gets 85% of the work done. So then it's just the last little bit of hooking up pieces that different centers would have to do. So I think there's some new tools that are coming online that will help that. And then of course, the last stage is sort of the interoperability tools, right? Things like Smart on Fire and some of these other technologies, which are supposed to make it not just across Epic centers, but across any EHR. And I think they're still very much in their infancy. They have so many barriers to being able to be utilized, but I'm hopeful that over the coming years, that technology will improve, centers will get more comfortable, so then we can start building these tools outside of the EHR that interface more broadly. So I think we're gonna get there. We just have to keep pushing, and there's clearly a lot of policy elements that can help to encourage that to happen. But I think we as clinicians also have a strong voice to be able to be asking for that to happen as well.
Thanks, Grace. And hi, Zoom, of course, crashed just at the crucial moment, but I just wanted to pop in quickly and say thank you to Jeff for a wonderful talk. And it's nice we can see the change over time because of the facial hair. I just wanted to mention that Grace Lind is a core faculty member at IHPS, an associate professor of medicine who does a lot of work in cardiology, and most importantly, an alum of the Emerging Scholars Program. Sarah Garrett is a health policy fellow, and she has another question for you. But before I hand the mic over to her, I just want to make sure to say a real deep thank you to Jay and to Beth, who have arranged for all of this and made this all possible. And it's gone fabulously, except for my own computer crash. So Sarah, please take it away. Grace had a sort of substantive question. Sarah has, I think, a really fascinating process and career development question.
Thanks. And Jeff, thank you for the really interesting presentation. It's a fascinating body of work. Yeah, I have a question more about process. You put up that slide where you showed, a variety of stakeholders you engaged for your K. And I just wonder if you could talk a little about what were some of the benefits of bringing together diverse stakeholders like that in that process, and what were some pitfalls or challenges? Thanks.
Yeah, no, that's a great question. And Dan, the facial hair comment's a good one. When I recorded this, I had just come off service. So of course I had to be ready for an N95 mask, but now that I'm off service, I can regrow the beard again and try and enjoy that. Sarah, it's a great question. When we started that project, I knew that I could bring anticoagulation expertise, but I don't know anything about sort of endoscopy. And so I had to sort of have that, collaborator come on board. And what I didn't realize was how critical he was going to be in getting buy-in from his division. So the director of the endoscopy unit, the first 2 times we went to her with the project idea, said, no, we don't have any issue with this, right? And it was so critical for me to be able to have him saying, I do these procedures, this is a major pain point, and here are some of the data to sort of back it up. And so it was really critical to have that voice there just to get the project launched. Once we did, and we started to bring the rest of the team together, I think the biggest thing that we learned was we all assume we know the process, but as they teach you, if you go through, any good lean program, is that when you show the humility and respect to go and ask the person doing the process, you'll learn so much more about it. And in our first group meetings, we were always saying, oh, well, when I place this order, then you do this with the information and that leads there. And as we started to listen more, we would hear from people, well, actually, no, when I get this information, I have to do these 3 or 4 things and it goes in this other direction. So we uncovered so much more about the process by having everyone in the room. And so that was, I think, really critical. The IT folks, if we had not had them on the team, I don't think we could have prioritized building the tool and the iterations we had to go through. So it was so important to have them there at the table so they could really say to their leadership, yeah, I need this here. And the patient voice was also really important. A lot of time they were listening to stuff that was kind of above their head, but it forced us to sort of get away from our jargon and to try and talk more generally. But when we developed some of the tools, they really pushed back and said, hey, this doesn't make sense to me, or this isn't important. And I think they challenged us, and through that sort of uncomfortable challenge, we came up with a better product, and I highlighted one of them. We were just going to put in our report, hold the drug for this many days. And they said that doesn't make sense to me. That language isn't clear. And it was through a lot of iterative work that we came up with the calendar approach that really fit. And so having their voice, I think, really improved the end product that came out of it. So it was so critical. The success was because of the team members. The challenge was getting them all together and scheduling it and getting all of their leaders to say, yes, you can do that, right? So the nursing and the schedulers, right? Like getting the nurse manager to say, yes, you can take that time away, getting the IT managers to say, yes, you can go and work on this project. And so it took a lot of data, it took a lot of convincing, but it also took using sort of some leaders to sort of help bring weight and say, this is an important project, we need you to prioritize it. And so that's the approach we took. Hopefully that's helpful.
Thank you.
Thanks. Jared, do you want to jump in? We'll squeeze a last question in.
Okay, real quickly. Jeff, welcome to UCSF. I'm delighted you had such a great week or visit. And I also want to thank Dan Dohan for all the work that he's done to establish this exchange. My question on the chat, and if we don't get to it, it's okay, is really around systems change and closing the gaps in terms of going to scale with the use of evidence, whether it's following new guidelines or other kinds of change introduction. And you have started to answer this question, but I was just wondering if there are any other insights that you've gained about the challenges in scaling these kinds of interventions into the future, so we can close that gap between evidence and practice. Thanks.
Yeah, no, it's a great question, and it's probably the question I'll continue working on throughout my career. I think some of the things that I've learned, coupled with sort of some of my religious beliefs, if you want to call it that, is that it's hard to get a wide body of people to all do something. So the more you can focus it into a narrow group, the more you can have control and you can minimize variation. That was clearly one of the lessons we learned from that pre-endoscopy project, right? Rather than having hundreds of docs and nurse practitioners do this, let's focus it into 4 pharmacists who are following guidelines. So that, I think that's when possible, the more you can sort of highlight that and then say there's value in that, so therefore those people's jobs need to be supported and resourced, is really critical. The other piece that I think, as I put on sort of the technology hat, is you know, we're inundated with all of this information, and especially within an EHR, right? There's more alerts and more pop-ups. And what I've heard from the folks who've used these tools is that this is, the BPA in particular is one they like because it reduces their workload. It doesn't add to their workload. And so when we can create processes that make it easier for somebody, we can offload something they used to have to do or they didn't know how to do, and we can operationalize it, and we can make it so that it's streamlined. We can probably improve care delivery while also making that clinician happier. So in the era of burnout and everything else, I think that's sort of an important, it's an important design principle. And I know that that won't apply to everything and it won't solve all problems, but it's something I try to include as I think about approaching these different evidence to practice gaps.
Well, thank you, Dr. Barnes. This was just fantastic. And I'm going to give you a round of applause here in Zoom fashion, and also give you a chit for a future visit to San Francisco, because we all missed the opportunity to take you to dinner and to meet you in person. But it was a fascinating talk. It's amazing, impressive body of work. And we look forward to hearing more about your fantastic research and impact on practice in the future. Thank you.
Well, thank you so much for having me. It's really great. And thanks everyone for joining today. I look forward to seeing you all in person and sometime soon.